So I've been listening to what our various speakers have been saying and to a lot of the questions from the audience and trying to determine what, if anything, is one common thread that weaves through everything. I must say probably the most inspiring remarks I heard, and not unpredictably, came from Carolyn as a frontline staff worker with 30 years working directly on a daily basis with our people, because there's nothing that grounds you more than the individual face every day of the seniors in our care system, because what that does, and Carolyn so articulately and passionately presented it, reminds us that everybody is an individual. We come to our lives as individuals, we live our lives as individuals, and we come to the end of our lives as individuals. And so that is the one theme that is resonating when we talk about the care for people, is that we need to recognize the differences that everybody has, and that when they come together in a residential care facility, they don't homogenize into one person with one common set of desires about what to eat, when to eat, who to live with, how to live. Those are all very different throughout our lives. And one of the things I think we forget is that the many, many issues a person is grappling with when they come into the residential care system. Let's be honest, nobody aspires to live in residential care, right? We have to remember that. So somebody is coming, first of all, to residential care out of necessity, not out of want. So think about how that presents when you are then, you're not really where you want to be. You're where you need to be for the most part, but not where you want to be. Now you're going to have to live with other people. You may not have lived with other people most of your life, but now sharing every breakfast, lunch, and dinner are 30, 40, 50, 100, 200 other people. Sometimes sharing your room, 1, 2, or 3 other people. You don't get to watch what you want on television. It's what everybody agrees on or votes on or is on the screen. So I think we need to understand all of what's going on with the person who's there. And I think what we really need to do is think about, what if that were me? Because person-centered care, you could argue, starts with thinking, we're a person. What would we want? How would we want it? And then we can begin to understand that, yeah, I'm not going to want everything the same as everybody else. And it does relate to how we have structured our care system, arguably in North America, Canada. I don't think that British Columbia is a whole lot different from other provinces. We have some differences to the US, but actually not a whole lot. We have vast differences to other countries and cultures. But we have fashioned it to some extent on the medical system. And what we have to remember is the medical system is built on, we are here to cure you and fix you. That's why you go into a hospital. You go to a hospital to be cured and fixed. We don't go to live in residential care to be cured or fixed. We go there to live because we need supports that can no longer be met in our individual homes and on an individual basis. And so when we think about what we value and what we measure, I think we need to do a better job of understanding what's important when you're living in residential care. You're not there to be cured or fixed. You're there to live. And our system sometimes values things that are important in a hospital setting. They are important in a medical system, and they are important in measuring quality and success when we are curing you and fixing you. but maybe they're not quite what the people who are living in residential care are valuing. And I think Carolyn wrapped that up very succinctly. It's about, I want to get my hair done. I want to go out on an outing. I want to live. Because one of the little boxes of outcome of care that we check off, we have these little boxes, everybody that works in the system will know what I'm talking about. Immortality is not a box we can check. I don't think we've actually come to grips with that. I think we might find people in residential care have come to grips with that. I don't know. I have the humility to know that I can't possibly know what it's like to be 90 years old, to have watched my friends die, to have my body falling apart and have betrayed me to the point where I can no longer meet my most basic needs. I can empathize, I can think. I cannot actually know. So what we need to do is go to those people and ask them what they value, and then provide it to them. And we have to be prepared to accept that what they value might be different than what we think they should value. And we need to have a system that accepts that that's okay. So we're doing this for the first time, a survey of every resident in residential care in this province. All 28,000 folks are going to be asked the same questions. So we're going to be able to get a really big picture of what people in this province think about residential care and what they value. And we're going to be able to see it by facility, and we're going to be able to do all those wonderful things that Marcy and Jennifer like to do, where we take the numbers and we cross-reference and we can show you that, you know, it's likelier over here and likelier over there, and that will all be very good stuff. But I think we have to prepare ourselves for what comes back is more about the support for me living as an individual in residential care. And you know, relationships have been talked about a lot. And certainly as human beings throughout life, we value relationships. We are social animals by design. We are not solitary beings. That's not who we are. And so I think we're going to hear some interesting messages from our people who live in residential care. And you know, going through the experience of designing this residential care survey and how we're going to administer it has also been fascinating. Actually Carolyn has been part of the group, and there's others in the room here who've been part of the group of designing this survey. But the first battle we had to fight was with the policy experts at the University of Waterloo, who know a lot, and they're very smart people. They're actually far smarter than I am. And they know all about survey design and survey methodology, but they've never spent one single day in a residential care facility or with people who are 95 or 98 years old, whose what we call the RIE score might indicate that they have significant or moderate cognitive impairment. But we know, actually, they still have opinions about whether they liked that meal or whether there was enough time for them. Actually, they still have that. And so the first battle was a whole bunch of people in Alberta, in fact, and actually I do compare us to Alberta. Sometimes it's good and sometimes it's bad. But in Alberta, they made a decision they weren't going to survey any residents, just the family members, because the residents couldn't competently answer the questions. And then in another part of the country, they said, we're not going to ask any resident who's what we call a CPS score, a cognitive performance score. So higher level means less cognitive impairment. Higher score means more cognitive impairment. Lower score means less, so low score is good. They weren't going to survey anybody with a score over 2, CPS score over 2. So I would have none of that, and those who sat around the table know the little battles we had to fight. And lo and behold, we went out and we cognitively I said, everybody is going to be asked. I'm not naive. Everybody isn't going to be able to answer. We all know that. But that is fundamentally important. And lo and behold, when we did our, what they call the cognitive testing, which is we go out to facilities and we test this, we got meaningful answers with people who have CPS scores of 4, right? And that's pretty profound to recognize. And I think that those who have worked on the front lines know that people have value and their opinions have value, irrespective of their physical or cognitive impairments. And that's part of person-centered care. I was interested to hear of the example from Sweden. I'm often struck by my poor colleagues in Sweden must never get out of the country, because who do they possibly go and study? For anything, because it's not just residential care, there's all these Swedish healthcare studies. But I was very, very proud to be part of the first licensed dementia housing that we had. I think it was in the country, it was certainly in BC. I didn't dream it up, it is imported from the Netherlands, but it is exactly the premise being a small group of people in a house-like setting with sufficient staffing and the right kind of staffing, and again, not over-medicalizing it. So instead of nurses in charge, we put physical therapists in charge, and instead of nursing staff, we had care aid staff that were there on a day-to-day. There was nursing oversight, yes, for those clinical. But you know, it's a funny thing. We, because I am embarrassed to say, most of my career was more pushing paper than dealing directly with the people, but I did have some frontline experience as well. But I could see what was going to happen, and lo and behold, we did a study and it showed some great outcomes. And so the first thing I said was, okay, when you don't have the nurse model, you still need nursing services, so you have to bring the nurse in, so it costs more money, right? So the first thing I said was, you know, they're going to change this model to have a nurse in charge, because otherwise you are having to pay twice. And then the other thing is the number of people is going to increase and increase. And lo and behold, when I started out, 12 was the optimum size. We actually started with 14, and now apparently 25 is the optimum size for the groupings. And so it grows and so it grows, because we try to rationalize how we can be more efficient is the word. Somebody has talked about the model where it's not a different person delivering the care or the services all along. You don't have somebody who just does the meals and somebody who just does the housekeeping and somebody who just does. And certainly from my experience, I am very wedded to that model. I had the privilege of working both in residential care and in home care. And what I saw was the capacity for frontline staff, both in home care and residential care, are not only very caring people, they spend the most time with the resident and are the most observant and able to observe things that change. And I think that giving a wider scope and more autonomy to look after the whole person and their needs actually has much to say for it. And I hope that we can move forward in developing that. But we are going to have to come to terms with this issue of the level of support, whether we want to call it staffing and what kind of staffing, that is required in our care facilities. Somebody asked, I think it was Carolyn, about how our residents have changed over the years. I've seen it both in home care, by the way, and in residential care. And so one of the measures is what we call your average length of stay in residential care. And in some health authorities, it's actually less than a year now. So that tells you about the fairly high level of what we call acuity that people are coming into residential care with. And certainly that's reflected by what I saw in the community, which is when I started 20 years ago, we might be caring for 10% of our roster at extended care level, and the other 90% of our roster weighted down at what we would call personal care level or intermediate care level 2. When we look at the analysis of our home care population, 50% of them, 50% of our people on home supports in this province have the same clinical profile as our people living in residential care. So you can see that by the time people are coming to residential care, they're fairly far advanced. Some are coming earlier because of circumstances, often driven by the death of a spouse and no living caregiver. I've joked that if the province really wants to assist people to live independently in their home, they should invest in a geriatric dating service because one of the big drivers that puts people to residential care or indeed even on home support is the loss of a spouse. And then if they don't have a family member that they can live with, that does require them to move into assisted living or residential care. So clearly people are sicker, frailer, I think, not sicker. They're frailer than they were. It's interesting, we just did this monitoring report to note that a couple of things. We haven't built any new residential care beds in the last year, and I'm going to use the last year because this is where so we had no new residential care beds. Our wait times are up, but our admission rate increased by 7%. And so what that tells you is it's about the turnover, right? And how we are going to deal with the increasing turnover. That is a different staffing level. That is a different environment that's created when residents are coming in for a year or less. But I've also been struck by how in the very, very beginning of my career, now 25 years ago, I did do some work in childcare. And we have childcare regulations, and we have very enshrined in regulation. This is how many, if you're an infant toddler, this is used to be 4 to 1. I think it's actually now 3 to 1. If you're 18 to 36 months, this is the, and so we actually have a model out there that recognizes differences. So caring for an infant is different than caring for a 4-year-old. Well, if we think about residential care, we do have a spectrum of different care needs within residential care, but we've blended it all. It's the unintended consequence. I can remember, I think it was 15 years ago now, when we moved from levels of care to one level complex care. And we meant well, and I actually was part of the supporting that decision. I was not against that decision. We did it because we said, this isn't, people are having to move from one facility to the next, and really what they should be able to do is age in place, right? So you can see it came from good intent. But the unintended consequence 15 years later is we have only one level of care, even though we have a variety of people in care, particularly when you look at the difference between those who have severe cognitive impairment and those who don't. And perhaps they need different staffing levels, they need different environments, they need different kinds of care, but we've blended it all together. And so I think we're going to have to come to terms with that and to recognize that just as there's individual care, within that individual care there are communities of interest within our residential care facilities, and that staffing will need to be at that level. The other thing I remember from my days in childcare was childcare's licensed just like our residential care, and you get a visit from the licensing officer, but actually if your staffing isn't what it's supposed to be or it doesn't have the certification it's supposed to be, that's actually a licensing infraction in childcare. It's not a licensing infraction in residential care. They make sure that you've got the paperwork on file. It's an interesting thing when we look at what we are caring to measure as licensing infractions in our care facilities. I'm not sure that we've really kept pace, again, with what's really important to the experience of the person in residential care versus what the system is valuing in our residential care facilities. And I'm also struck by the fact that when you're an employer and you are governed by WorkSafe BC, and you have environments that are deemed unsafe for your workers, or your workers have accidents, there is a financial penalty for employers for that, right? Your premiums go up. And so you have a very heavy incentive as an employer to ensure that you have safe workplaces, and it's all very tracked because it's valued. We don't have that system in place, by the way, for our residents. So if you have a licensing infraction in a residential care facility, and licensing is looking at the residents, WorkSafe BC is looking at the care of the staff, there's no penalty. You get written up, doesn't look good, but nothing materially happens to you, right? And so, because we also know that in legislation, so some knowledgeable person's out there is going to say, well, actually we can close you down. And yes, that's true. But the system that's deciding whether or not to close you down is the system that has to figure out where to put the 200 people that are in your facility. So they have a heavy incentive to make it look okay and to give second, third, fourth, fifth, and 65th chances to facilities to get it right, because otherwise they've got to deal with where to put the people. It's part of the problem of putting licensing back to health authorities. It used to be with the province and more centralized. So that's an interesting issue that I think we're going to have to look at. And the woman who spoke about her husband, the discharge from the hospital and the dementia care, lots of themes resonated there. We are looking at hospital. I'm struck by the fact we're looking at this whole resident-on-resident aggression. In part driven, we now have the data for 1 year by facility. In part, this was driven by the coroner, who indicated that in a 3-year period of time, 16 people had died as a result of resident-on-resident aggression, but half those people were in hospitals. Only half of them were in residential care facilities. And part of it is we don't have secure facilities in the hospital. And you're quite right, we don't have the staff training, never mind the staff resources in hospital. But the other thing that you mentioned was that you have the good fortune that you were able to have private care to assist your husband. And something that I'm very committed to is that there shouldn't be a difference of experience because of the amount of money that you have. Your ability to be kept safe shouldn't depend on I have more money and I can hire somebody to keep my husband safe in a facility. So where do we go from here? Well, as I said, we are, my office is undertaking this residential care survey. I think it will probably be completed and analyzed by the end of the year. It might be a little bit into 2017. It's a mammoth undertaking, I have to tell you. And I also have to tell you the government supported this. It's not, I think it's going to cost like $1 million to do, because everybody has to be personally interviewed, and it's going to require about 1,000 volunteers to help us with it. It's not something we can do every single year, but it is, I think, going to be very important. The other thing that's happening sooner than this, in the next couple of weeks, we've just completed our directory of facilities, and we will be posting it online and publishing it, and it's a standardized directory. And so you're going to be able to go and look at facilities, and if you choose to compare, you can, or look for themes, you can, because we'll indicate whether it's under the Hospital Act or the Community Care and Assisted Living Act. We'll indicate whether it's private or public. We tell whether it's cooking its meals on site or contracting them out. And we also tell how many incidents it had, critical incidents it had. We tell licensing inspections, any outcomes of those licensing inspections. We tell how many hours of care are provided per resident per day for that facility. We're talking about the RI data, so we're able to link their use of antipsychotics, antidepressants, their physiotherapy, recreational therapy. People will be able to go. This is how things change. The first thing you have to do is make the information available to everybody to see. That's the first thing to do. See where the issues are and then go in and fix them. And the only other thing, I'll wrap up because I know you're getting hungry, but Lorraine talked about big A advocacy and the call to action. I am a firm believer that at the end of the day, the government is the people. And if the people want it, the government ultimately will deliver it. And I think that part of the message that I am trying to put forward to government, I call it the myth busting, but is to recognize government's fear that they can't control costs in the future. They like things that they can control today, right? They like to give a grant, finite amount of money, we know. They don't like to fund programs without, that don't have criteria that they can know we're gonna fund 1,000 people a year for this versus we're gonna fund anybody who has this particular condition. But one of the things that I think we have to recognize is that yes, our population is aging and yes, the numbers are increasing, but the percentage of people who will require residential care is actually reducing. It'll never go to zero. There'll always be residential care. And in what we call absolute numbers, yes, it's going to increase, right? But the hysteria around some of these exploding costs, when you actually look at the numbers and you recognize that the investments we're making in home and community care and how they're going to, and assisted living, and then residential care, it is achievable because we're going to see a lesser percentage. And the population overall is growing. The other thing the dramatists like to do is just talk about how much the old people are increasing. All the population is growing. Yes, the percentage that will be seniors is incrementally increasing, but at a rate of less than 1% a year. So I think that if we can remind governments that more investment is needed, but the good news is that as the population grows, a smaller percentage may need this. They may see that as more palatable and more achievable, because I do agree that what do the politicians say? They campaign in poetry and govern in prose or something. And so I think we have to remember, because sometimes in these forums, which is all of us committed, we speak in poetry, that the action and the reaction of governments will be in a more pragmatic way. But I do think that we need to ensure that the voice of seniors and their needs are heard. And I think it's important when that goes forward to understand that the majority of seniors actually are taking care of themselves. And those seniors actually want to help to take care of the seniors who aren't able to take care of themselves. Because you still pay income tax at age 66, 67, 68, 69. Now I know there's a couple of people on the Sunshine Coast that actually think once you're 65 you shouldn't have to pay tax anymore. But I don't think that's going to make it. But I think that that's also another important message, is not to portray seniors as a burden, because seniors aren't a burden. The vast majority of seniors are actually taking care not only of themselves, but of other seniors, those in need, right? And that's what we need to remember. So I thank you all. I really want to thank the panelists. I think this is fascinating work, Margaret and Megan, that you've done. I'm looking forward to digesting it some more. And we will keep the dialogue going, and hopefully you will find some of the work coming out of our office over the next year or so helpful in our commitment to move things forward. Thank you, and bon appetit.